Hello friends, welcome back to my channel. This video is all about GI system. Starting with physiology of GI motility, it is based on basal electrical rhythm as well as mechanical movements. Intestinal RMP. What is intestinal RMP? Intestinal resting membrane potential. It is minus 45 to minus 65 voltage. Telling about pacemaker of GIT, interstitial cells of Kajal, which is the pacemaker of GIT, maximum located in pylorus of stomach. When acetylcholine stimulation is given to intestine, acetylcholine is increasing the spike potentials, which causes increase in contraction of the intestine. But when epinephrine is injected, there is decrease in spike potential and decrease in movement, that is decrease in contraction. What is BER? BER is basal electrical rhythm. So maximum basal electrical rhythm is with duodenum, that is 12, and minimum basal electrical rhythm is with cecum. The number is 2. So duodenum, the basal electrical rhythm of duodenum is 12, which is maximum. Jejunum, it is 11. Ileum, it is 8. Sigmoid, 6. Stomach, it is 4. Cecum, it is 2. So maximum BER is in duodenum and minimum BER is in cecum. Maximum BER in duodenum, that is 12, and minimum BER is in cecum, which is 2. Next is about mechanical movements. There is segmentation, peristalsis and migratory motor complexes. So segmentation and peristalsis are the fed contraction which helps in propulsion of food. Migratory motor complexes, MMC, it is hunger contraction or housekeeping contraction. Segmentation is within one loop of intestine, food undergoes churning. Within one's intestinal segment, mixing movement happens. That is about segmentation. Next is about peristalsis. Peristalsis means one segment contracts and other segment relax. Here there is forward propulsion of food bolus. Substance P and acetylcholine induces contraction. That means this substance P and acetylcholine, it increases the contraction, which induces the contraction. So V, I, P and NO, they are inhibitory neurotransmitters. They are inhibitory neuropeptides which decreases contraction. In achalasia cardia, VIP and NO are absent. So there is failure of peristalsis. That means there is failure of relaxation. Next is migratory motor complex, which is MMC. It is regulated by motilin. It occurs in hungry state. After you have meal, for about 90 to 120 minutes later, that means 1.5 to 2 hours later, MMC begins. And from stomach to distal ileum, they are progressing at a rate of 5 centimeter per minute. Motilin receptors like macrolides, which is motilin agonist, they increase GI motility. There are 3 reflexes to be studied. One is enterogastric reflex. Enterogastric reflex means here the duodenum is distended. So it is asking the stomach to relax, or it is making you stop eating. Is enterogastric reflex, it prevents the action of the stomach. It is the inhibition of the stomach action by intestine. So there are 3 hormones which cause this enterogastric reflex. They are CCK, secretin as well as peptide Y. And this enterogastric reflex, it is stimulated by fat, protein, carbohydrates and also acidity of chyme, and osmolarity increases this reflex. So osmolarity increases enterogastric reflex. This enterogastric reflex is stimulated by fat, protein, carbohydrates and acidity of chyme. Next is about gastrocolic reflex. So in newborn babies we give milk or food, and immediately after milk or food they pass stool. So this is about the gastrocolic reflex. What happens is there is gastric distension which is causing colonic contraction. So this is a positive reflex. Gastrocolic reflex is a positive reflex, and it is more common in sigmoid colon, which contracts after gastric distension. Next is gastroileal reflex. Gastroileal reflex, what happens is there is gastric distension, there is relaxation of IC valve, so food passes to the large intestine. Next, about gastrointestinal hormones. First is gastrin. Gastrin hormone increases acid secretion in stomach. There is G cells which is present in antrum of stomach and duodenum. Gastrin hormone increases gastric acid secretion. Gastrin hormone increases gastric motility. Gastrin hormone increases by taking chronic PPI use, that is proton pump inhibitor use, chronic atrophic gastritis, as well as Zollinger-Ellison syndrome. Chronic atrophic gastritis, it is related to pernicious anemia, which is an autoimmune destruction of parietal cells. Here H plus is not getting produced, so more gastrin is produced. Gastrin is stimulated by amino acids, vagal stimulation via GRP. Gastrin hormone decrease by pH less than 1.5. Gastrin hormone, it has positive feedback by stomach distension. Next, about somatostatin. Somatostatin is produced by D cells in the pancreatic islets. Somatostatin decreases gastric acid and pepsinogen secretion. Somatostatin decreases pancreatic and small intestinal fluid secretion. Somatostatin decreases gallbladder contraction. Somatostatin decrease insulin and glucagon release. Regulation of somatostatin is increases by acid and decreases by vagal stimulation. Somatostatin analog is octreotide, which is used in acromegaly, carcinoid syndrome, VIPoma and variceal bleeding. Next, about cholecystokinin. Cholecystokinin is produced by eye cells, which is in the antrum, duodenum, jejunum. Cholecystokinin is regulated by fatty acids as well as amino acids. Cholecystokinin increase the pancreatic secretion, which stimulates hormone more than bicarbonate excretion. Cholecystokinin increases gallbladder contraction. Cholecystokinin decrease gastric emptying. Cholecystokinin increase sphincter of OD relaxation. Cholecystokinin hormone acts on neural muscarinic pathways to cause pancreatic secretion. Next hormone is secretin. Secretin is produced by the S cells in the duodenum. Secretin increase the pancreatic bicarbonate secretion. Secretin decrease gastric acid secretion. Secretin increase bile secretion. Secretin is regulated by increase by acid fatty acids in the lumen of duodenum. Secretin increase the bicarbonate, which neutralizes gastric acid in duodenum, allowing pancreatic enzymes to function. Next hormone is GLP, that is glucose dependent insulinotropic peptide, which is also known as GIP, that is gastric inhibitory peptide. GLP or GIP, it is regulated by fatty acids, amino acids as well as oral glucose. GLP is produced by K cells in the duodenum as well as jejunum. Exocrine function of GLP is it decrease gastric H plus secretion. Endocrine function of GLP is it increase insulin release, which causes increase in satiety by decreasing gastric emptying and inhibits the release of glucagon. GLP is also known as GIP. Oral glucose load increases insulin compared to IV equivalent due to GIP secretion. Next is vasoactive intestinal polypeptide VIP. VIP increase intestinal water and electrolyte secretion. VIP increase relaxation of intestinal smooth muscle and sphincters. VIP increase by distension and vagal stimulation by adrenergic input. VIP or vasoactive intestinal polypeptide, it affects the parasympathetic ganglia in sphincters, gallbladder as well as small intestine. One syndrome associated with this VIP, vasoactive intestinal polypeptide hormone, is VIPoma. VIPoma means there will be WDHA syndrome. What is WDHA syndrome? W and D means watery diarrhea. H means hypokalemia. A means achlorhydria. So next hormone is ghrelin. What is ghrelin? Ghrelin is the hormone which increases appetite. It is in the stomach. Regulation of ghrelin is it increase in fasting state and also by food. Ghrelin is increased in Prader-Willi syndrome and it decreases after gastric bypass surgery. So ghrelin increases in Prader-Willi syndrome. In Prader-Willi syndrome, there is paternal deletion as well as maternal silencing. It is seen in Prader-Willi syndrome is seen in fat babies. There will be hyperphagia. Babies will be hypotonic. Next is about the GI secretions. Total volume is 7 liters per day. Maximum secretion is by stomach in terms of volume. Most alkaline pH is in the Brunner gland in duodenum. pH is approximate to 8. Most acidic pH is stomach. pH is 1.5. In 1 liter, maximum potassium concentration is in colon. Overall total volume, the maximum potassium amount is in the saliva. Telling about the parts of the stomach, first about the fundus, there is mucus cells releasing bicarbonate and trefoil peptide, which is a mucus stabilizer. It helps the stomach to protect against acid secreted. Next about the body, there are parietal cells and chief cells. So parietal cells in the body of stomach secretes HCl and intrinsic factor. Chief cells are for pepsinogen. Intrinsic factor binds to B12 causing absorption. Here the antibodies are against this causing pernicious anemia where H plus and intrinsic factor is not produced. Most potent stimulus for H plus is histamine, which is produced by enterochromaffin cells or ECL cells. Further, it gets stimulated indirectly by gastrin to the circulation. Next about antrum of the stomach. G cells produces gastrin. There is mucus cells present. There is D cells which is the produced by the somatostatin in the antrum. Next about proximal duodenum. There is 3 cells to be remembered in proximal duodenum. S cells which produces secretin, I cells which produce CCK, K cells which produces GIP. Next about iron B12 absorption. Iron B12 absorption, just remember a code iron fist bro. So first iron means it is absorbed in the duodenum. Iron fist bro, fist means F for folate. Folate is absorbed in jejunum and iron fist bro B for B12. B12 is absorbed in ileum. So iron B12 absorption, we should remember iron is absorbed in the duodenum, folate is absorbed in the jejunum, B12 is absorbed in the ileum. B12, there are 2 main protectors. Salivary glands produce haptocorin. When B12 and haptocorin bind together, they travel in the intestine and it is digested by pancreatic enzyme. When haptocorin is removed, B12 and intrinsic factor together by the parietal cells of stomach. That means the B12 combining with the intrinsic factor by the parietal cells of the stomach, it forms B12 intrinsic factor which causes pernicious anemia. So B12 absorption will suffer. Next is when B12 and haptocorin together, when it is digested by the pancreatic enzyme, it causes pancreatitis. So then also B12 absorption will suffer. If there is distal ileum pathology like Crohn's disease, TB, Whipple's disease, then also B12 absorption will suffer. Next about the iron absorption. Iron absorption, first step is Fe3 is converted to Fe2 plus, and here the Fe3 to Fe2, that transporter is DMT1 which is present on the intestinal mucosa. Then it goes to the blood vessel through ferroportin. Hepcidin, it is a negative regulator which is responsible for anemia of chronic disease, and again Fe2 is converted to Fe3. First I told Fe3 is converted to Fe2 plus by DMT1, but now at last stage what happens is Fe2 is again converting to Fe3 plus, which binds to plasma transferrin which gets circulated in the blood and it then goes to the erythroid marrow. Now, acetylcholine, it is causing vagal stimulation, which causes direct stimulation and acts via GRP, which stimulates the G cells to produce gastrin. Most potent acid stimulus is histamine, which is H2 receptor, where gastrin indirectly acts via this. Next, about the acetylcholine stimulate the G cells, which stimulate the ECL cells to produce histamine. H2 blockers are cimetidine, famotidine, nizatidine. Cimetidine, it is not used nowadays. Cimetidine is CYP inhibitor. Side effect of cimetidine is gynecomastia. Somatostatins and prostaglandins act via GI. It inhibits the release of H+. So, give PG analog, that is misoprostol. But there is an exemption. For NSAID induced peptic ulcer, prostaglandin release is inhibited, so there is more H plus secretion, then you can give misoprostol. Drug of choice for all other is proton pump inhibitor, which is given to stop further acid secretion. Next is proton pump inhibitors secreting H plus R. Omeprazole, lansoprazole, pantoprazole. So, omeprazole, lansoprazole, pantoprazole, these all are given for all other ulcers. But in case of NSAID induced peptic ulcer, we give misoprostol. Proton pump inhibitor like omeprazole, lansoprazole, pantoprazole, these are hit and run drugs. Once they block proton pump, inactive for 24 hours until a new proton pump is formed. Side effect of proton pump inhibitor is Clostridium difficile induced pseudomembranous colitis and also allergic interstitial nephritis. Omeprazole interact with clopidogrel. This omeprazole and clopidogrel both interact via CYP2C19. Next, about antacids. Antacids neutralize acid in an emergency. Examples are aluminium hydroxide and magnesium hydroxide. Here, aluminium hydroxide, it causes constipation. Magnesium hydroxide causes diarrhea. Next, about calcium carbonate. Calcium carbonate, one thing we should remember is it has a side effect of milk alkali syndrome where there is hypercalcemia. Next, about triple drug therapy. We give 2 antibiotics along with 1 proton pump inhibitor, that is CAP regimen. C for clarithromycin, A for amoxicillin, P for proton pump inhibitor. So, triple drug therapy is clarithromycin plus amoxicillin plus proton pump inhibitor. Another thing is sucralfate and bismuth. These both are ulceroprotective drugs. Next is about constipation. Bulk forming drug is methyl cellulose. Osmotic drug is lactulose as well as PEG. We should increase water intake or it can cause dehydration when we use osmotic drugs like lactulose as well as PEG. Next is stimulant. Stimulant example is senna and bisacodyl. Side effect of senna is melanosis coli. Chloride channel activator, it is lubiprostone. Guanylate cyclase agonist is CGMP, which include linaclotide as well as plicanatide. 5-HT4 agonist is procalopride. NHE3 inhibitor is tinapanor, which is sodium hydrogen exchanger inhibitor. Peripheral opioid inhibitor is alvimopan, naloxone, methyl naltrexone. This peripheral opioid inhibitor, it is given for post-operative ileus. Next, about diarrhea, mu agonist is loperamide. It suppresses the bowel movement. Encaphelinase inhibitor is rasicodotril. Next, about vomiting, main receptors for vomiting are serotonin and D2 receptor. Vomiting is caused by the stimulation in brainstem vomiting center, that is 5-HT3D2. 5-HT3 blockers are ondansetron and granisetron. Ondansetron and granisetron, which is 5-HT3 blocker, they are the drug of choice for post-operative vomiting, that is early onset post-operative vomiting, post-chemo vomiting as well as post-radiotherapy vomiting. So, ondansetron and granisetron are given for early onset post-operative vomiting, post-chemo vomiting as well as post-radiotherapy vomiting. Side effects of 5-HT3 blocker, that is side effects of ondansetron as well as granisetron, is headache, QT prolongation, constipation, because here it blocks the serotonin in the intestine. So this ondansetron and granisetron causes constipation. Next, about the delayed post-op vomiting, delayed onset post-op vomiting, what we give is cisplatin. Cisplatin, it is an emetogenic anti-cancer drug. So this cisplatin, there is NK1 or substance P inhibitor, that is the aprepitant. So for delayed induced post-op vomiting, we give cisplatin, which is an emetogenic anti-cancer drug. It is NK1 or substance P inhibitor, that is aprepitant. D2 blocker is metoclopramide. What happens with metoclopramide is metoclopramide crosses blood-brain barrier. Side effect of metoclopramide is extrapyramidal symptoms. It inhibits D2 centrally, which induce hyperprolactinemia. Metoclopramide, it is also known as 5-HT4 or prokinetic drugs. Metoclopramide is D2 blocker. Another D2 blocker example is domperidone. Domperidone does not cross blood-brain barrier. Domperidone, it is the drug of choice for levodopa-induced vomiting. So D2 blockers are metoclopramide as well as domperidone. Metoclopramide crosses blood-brain barrier. Domperidone does not cross blood-brain barrier. Metoclopramide, it is a prokinetic drug which is used in gastroparesis. Domperidone, it is used for levodopa-induced vomiting. Vomiting centers are area prostrema, that is CTZ. Drug of choice is 5-HT3 blocker, that is ondansetron. Next, about motion vertigo. Motion vertigo, it stimulates cerebellum. It also stimulates the gag reflex, that is the pharyngeal stimulation affecting the cranial nerve 9. Cranial nerve 9 is glossopharyngeal nerve. Motion vertigo also stimulates the gastric mucosa, which is affected by the cranial nerve 10, that is vagus nerve. Gastric mucosa and gag reflex, which causes the motion vertigo. This mainly stimulates the nucleus tractus solitarius. Morning sickness, drug of choice is doxylamine and B6. B6 is pyridoxine. So morning sickness, drug of choice is doxylamine and pyridoxine. Mountain sickness or high altitude sickness, we give acetazolamide. Here there will be hyperventilation, so carbon dioxide is washed out. So there is respiratory alkalosis in mountain sickness or high altitude sickness. So drug of choice for mountain sickness or high altitude sickness is acetazolamide. For seasickness, drug of choice is meclizine. For motion sickness, drug of choice is hyoscine. Next topic is about ascites. Ascites, we should remember about SAAG, that is serum ascites albumin gradient. When SAAG, it is less than 1.1 gram per deciliter, portal pressure will be low. So it is not the portal hypertension. And also serum albumin, it will be very low, like in nephrotic syndrome. Ascitic albumin will be high because of exudative conditions. So if a patient is having frothy urine, it is something related to nephrotic syndrome. If a patient is having fever, weight loss, it is something related to TB. If patient is having weight loss and patient is an elderly patient, it is related to malignancy. If there is acute pain, that is a case of pancreatitis. So in all these cases, ascitic albumin will be high because of the exudative conditions. So next about the SAAG, serum ascites albumin gradient, more than or equal to 1.1 gram per deciliter, which indicates portal hypertension. So after that, we should check for ascitic protein, whether it is greater than or less than 2.5 gram per deciliter. So first, if the ascitic protein, if it is less than 2.5 gram per deciliter, it is the end stage liver disease, that is the cirrhosis. If the ascitic protein is more than or equal to 2.5 gram per deciliter, then it is Budd-Chiari syndrome, constructive pericarditis, restrictive cardiomyopathy. So If the ascitic protein is less than 2.5 gram per deciliter, it is end stage liver disease, that is cirrhosis. If ascitic protein is more than or equal to 2.5 gram per deciliter, it is Budd-Chiari syndrome, constrictive pericarditis, or restrictive cardiomyopathy. Higher SAAG means it is about the portal hypertension. SAAG, it is directly proportional to portal pressure. Low SAAG, that is low serum ascites albumin gradient, it is not equal to portal hypertension. So when SAAG is more than a value, more than 1.1 gram per deciliter, that is portal hypertension. Next is outflow obstruction, hepatic veins are blocked, IVC is blocked. So all these things are seen in Budd-Chiari syndrome. Outflow obstruction, hepatic veins blocked, and IVC blocked. These three are seen in Budd-Chiari syndrome, where there is ascitic protein more than or equal to 2.5 gram per deciliter, where SAAG gradient is more than or equal to 1.5 gram per deciliter. There is portal hypertension. Next, about the volume. When we do USG, we will see 50 ml of fluid, around 50 to 100 ml of fluid. So in fast also we see 50 to 100 ml of fluid. So in ascites case, when we do ultrasound, we see 50 to 100 ml of fluid. Shifting dullness, the volume is 500 ml of fluid, and in fluid thrill, it is 1500 ml. Treatment of ascites. In mild ascites, there is no clinical features. Ultrasound, when we do, we see ascites, and treatment is salt restriction. In moderate ascites, what we do is we do ultrasound, and also there will be clinical features of abdominal distension. So we give treatment like furosemide, potassium sparing diuretics like spironolactone, and also we give eplerenone. This spironolactone, it causes refractory gynecomastia. In case of severe ascites, patient will be having respiratory distress, so treatment is high volume paracentesis. Here the fluid is more than 2.5 liter, which is removed from the intestine, and also albumin is supplemented, that is 6 to 8 grams per liter of fluid is removed. Next, about diarrhea. Diarrhea, there is acute diarrhea as well as chronic diarrhea. If the diarrhea is less than 2 weeks, it is acute diarrhea. If the diarrhea, it is more than 4 weeks, it is persisting for more than 4 weeks, that is chronic diarrhea. In between 2 to 4 weeks, that is persistent diarrhea. So acute diarrhea, persistent diarrhea, and chronic diarrhea. Next is diarrhea presentation. If it is diarrhea presentation, if it is less than 6 hours, two things we should remember. One, about the Chinese food, which is the emetic type of diarrhea, which is caused by Bacillus cereus. Also remember MYPA medium. Also think about history of dairy products. If it is asked, and also diarrhea presentation less than 6 hours, then think about Staphylococcus aureus. Now another scenario is if the presentation of diarrhea, it is for more than 6 hours. Differential diagnosis are traveler's diarrhea. Think about ETEC, that is enterotoxigenic E. coli. There is heat stable as well as heat labile toxins. Heat stable, which increases cyclic GMP. Heat labile, which increases cyclic AMP. Next is rice water diarrhea. It is caused by Vibrio cholerae. Next, about the shellfish history, it is about the Vibrio parahemolyticus. If there is camping or persistent diarrhea or malabsorption, think about Giardia. If the patient is having acute right iliac fossa pain along with diarrhea for more than 6 hours, think about Yersinia. If patient is on antibiotics and if patient is having diarrhea more than 6 hours, think about Clostridium difficile. Next, about bloody diarrhea. If there is a history of bloody diarrhea and also in the history they are telling about poultry and eggs, then it is because of salmonella. If the patient is having severe dehydration, febrile seizures, along with it there is bloody diarrhea history, it is because of Shigella. Next is Guillain-Barré syndrome or Retter's syndrome. It is because of Campylobacter. Here also there is bloody diarrhea. The medium for Campylobacter infection is Scirrhomedium. Next case is if the patient is anemic or if the patient is having uremia, along with it if the patient is having bloody diarrhea, it is about hemolytic uremic syndrome. Think about O157 is to H7EHEC, enterohemorrhagic E. coli. Next case is flask-shaped ulcers. Along with flask-shaped ulcers, there is bloody diarrhea. There is history of amoebic liver abscess, ankylosis, amoebic dysentery, amoebic ulcers. Everything is about entamoeba histolytica. Next case is longitudinal ulcers along with bloody diarrhea. It is about typhoid. Transverse ulcers or stricturing ulcers along with bloody diarrhea. It is about TB. Next, about the chronic diarrhea. Chronic diarrhea, we should always rule out malabsorption. We should measure the stool osmotic gap, whether it is secretory or osmotic diarrhea. So, when we measure the stool osmotic gap is measured by 290 minus 2 into stool sodium plus stool potassium. That is the formula. 290 minus 2 into stool sodium plus stool potassium. So, when stool osmotic gap is less than 50, it is secretory diarrhea, and if the stool osmotic gap is more than 50, it is osmotic diarrhea, which resolves faster and it reduces on fasting. Secretory diarrhea, I told you stool osmotic gap is less than 50. It is a chronic case. So secretory diarrhea, we should remember two things. There are two differential diagnoses. One is Zollinger-Ellison syndrome and the other is carcinoid. In osmotic diarrhea where the stool osmotic gap is more than 50, which resolves faster and which reduces on fasting, there is positive hydrogen breath test which indicates lactose intolerance. Next, about the fat malabsorption. Fat malabsorption, stool fat is more than 7% in young males. There is a history of greasy stools. And also there is deficiency of fat soluble vitamins like A, D, E, K. We also do D-xylose test in fat malabsorption. We ask the patient to drink D-xylose. If you have proper absorption from intestine, there is high excretion in urine, and D-xylose test is normal in pancreatitis. Only fat absorption takes place. So D-xylose test is normal in pancreatitis. D-xylose is positive or abnormal in BOGS. What is BOGS? It is bacterial overgrowth syndrome, which is also known as small intestinal bacterial overgrowth. It is because of strictures or functional motility problem like diabetes mellitus. There is stasis as well as overgrowth of bacteria. So, D-xylose is positive or abnormal in bacterial overgrowth syndrome. Next is in mucosal disease like celiac disease, A beta lipoproteinemia as well as tropical sprue, there is D-xylose positive or abnormal. So here we give trial of rifaximin for 7 days. If patient response, D-xylose is normal, which indicates bacterial overgrowth syndrome. If it is still abnormal, it is a mucosal disease. So we should do biopsy. So in mucosal disease, we should check whether D-xylose is normal or it is abnormal. So if the patient responds to D-xylose, which is normal, then it is bacterial overgrowth syndrome, and if it is still abnormal, it is a mucosal disease. So we should do biopsy. Causes of malabsorption are flattening of villi, there is crypt hyperplasia present, increased lymphocytes in lamina propria, which mainly affects with iron deficiency anemia. Everything is about celiac sprue. Celiac sprue affects HLA-DQ2. It is an autoimmune disease. It affects the HLA-DQ2. Most commonly affects duodenum. Hypersensitivity along with cell-mediated immunity activates against gliadin, and CD8 T cells which is present in the lamina propria gets affected. In celiac sprue, there is risk factor for enteropathy associated T cell lymphoma. Treatment for celiac sprue is avoid gluten in diet like barley, rye, oats and wheat. So BROW, avoid gluten in diet, that is the primary management for celiac sprue. Celiac sprue is associated with dermatitis herpetiformis, IgA in papillary tips. So the treatment when there is association with dermatitis herpetiformis, we give dapsone. PAS positive bacteria which is diastase resistant is Triopherma whippeli, which causes Whipple's disease. There is foamy macrophages in electron microscopy. Cardiac involvement present, arthralgia is seen, neurological involvement is present in addition to malabsorption in Whipple's disease. Foamy macrophages which AFP positive, it is seen in GITB. Next, about inflammatory bowel disease. There are two diseases, that is ulcerative colitis and Crohn's disease. First, about ulcerative colitis, it affects the mucosa, which is the superficial layer. Most common site for ulcerative colitis is rectum. Strictures, fistula, abscess, these all are absent in ulcerative colitis. Skip lesions are continuous involvement from rectum to colon in ulcerative colitis. Antibody affecting ulcerative colitis is P-ANCA. Histopathological features in ulcerative colitis is crypt abscess. Imaging for the ulcerative colitis is when we do barium imaging, that is barium enema, we see mucosal granularity, that is the ohostral lead pipe lesions on colon. On gross microscopy, we see pseudo polyps. Classification for ulcerative colitis is True Love Witt classification. Treatment for ulcerative colitis is 5-ASA, that is sulfasalazine or sulfampyridine, oxalazine which has azole bond, and if it doesn't respond to the above said sulfasalazine and oxalazine, we give steroids. Then again, if it doesn't respond, we do surgery, that is total proctocolectomy followed by ileal pouch anal anastomosis. So this is all about ulcerative colitis. Next, about Crohn's disease. Crohn's disease affects transmural. Most common site is terminal ileum. Strictures, fistula, abscess, these all are very much increased in Crohn's disease. Skip lesions are present in Crohn's disease. Antibody in Crohn's disease is ASCA. Histopathological findings in Crohn's disease is non-caseating granulomas. While imaging, we can see aphthous ulcers which merge with serpentine ulcers to form cobblestone appearance of intestine. Classification of Crohn's disease is Montreal classification. Treatment for Crohn's disease is steroids. If it doesn't respond to steroids, then we give biologicals. Terminal ileal stricture, it shows string sign. On CT there is increased inflammation, vasa recta open up and it shows comb sign. So this is about Crohn's disease. Next is extra-articular manifestations of inflammatory bowel disease. If it responds to treatment of inflammatory bowel disease, it can cause peripheral arthritis, erythema nodosum, which is tender lesion on shin, episcleritis. If it doesn't respond to treatment of inflammatory bowel disease, there is axial arthritis. Spine is not involved. Spondyloarthropathy is the manifestation. Pyoderma gangrenosa, which is present on the shin, it has necrotic appearance. There is neutrophilic infiltration on histopathology. Uveitis is seen here. Primary sclerosing cholangitis is also seen here. Next, about GI polyps. GI polyps, there are neoplastic polyp as well as non-neoplastic polyp. So first, about non-neoplastic polyp, it includes hamartomatous polyp, which is the most common type. Serraceous margins are present on hamartomatous polyp, which is only on top 1/3. If it extends throughout the thickness, it is serrated sessile adenoma, which is also known as neoplastic polyp. Inflammatory cells are present. There is history of rectal bleeding and mucus discharge, which is an inflammatory polyp which causes solitary rectal ulcer syndrome. A 4-year-old child with rectal bleeding having cystic spaces within polyp on imaging. This is about juvenile polyp. It affects the SMAD4. Now about Peutz-Jeghers syndrome. Peutz-Jeghers syndrome, it causes mucocutaneous pigmentation around the mouth. Peutz-Jeghers syndrome, mainly the history will be like 11-year-old child with intussusception. There is mutation with STK11, LKB1. So this Peutz-Jeghers syndrome, it has highest risk of pancreatic adenocarcinoma. There is arborizing pattern which is showing a polyp which looks like tree. Smooth muscle is going into the polyp. This is all about Peutz-Jeghers syndrome. Now about hamartomatous polyp, there are two syndromes associated with this. One is Cowden syndrome and other is Cronkite-Canada. So Cowden syndrome, there is P10 mutation which is associated with breast carcinoma, endometrial carcinoma, thyroid carcinoma, trichomonas. Next about the Cronkite Canada, it is not inherited but there is polyps and ectodermal derivatives. Here there is alopecia, nail disease as well as skin disease. Now about neoplastic polyps. Neoplastic polyps, there are tubular type, villus type as well as tubulovillus type. Among these types, villus type has increased risk of malignancy. Now about the adenoma carcinoma sequence. Normal adenoma, there is AK53. APC at 5Q21, there is germline which is inherited, somatic which is acquired. There is mutations of cancer suppressor genes which is the first hit. Familial adenomatosis polyposis is this case which is autosomal dominant. So in familial adenomatosis polyposis there is APC at 5Q21 which is germline or somatic. Next about APC and beta catenin, that is the second hit where methylation is abnormal and there is inactivation of normal alleles. KRAS at 12P12 which causes proto-oncogene mutations. Next is TP53 at 17P13, LDH at 18Q21, SMAD 2 and 4. Everything is seen with juvenile polyp. There is homozygous loss of cancer suppressor genes as well as overexpression of COX2. Sessile serrated adenoma is associated with hereditary non-polyposis colon cancer HNPCC. Here the DNA mismatch repair gene issue is present with MLH1 as well as MSH2. TGF-BR2, BAX, BRAF mutations are present. Tumors associated with BRAF mutation are melanoma, adenocarcinoma of colon, papillary thyroid carcinoma, hairy cell leukemia, Langerhans cell histiocytosis. BRAF inhibitors are dabrafenib, vemurafenib, which is given for lung cancer BRAF mutations. Next is associations of FAP. Associations of FAP, familial adenomatosis polyposis, include Gardner syndrome as well as Tercoat syndrome. So, first about Gardner syndrome, it is affecting the ectodermal layers. There is supernumerary teeth. On X-ray we see osteoma. There is abdominal wall fibromas. There is congenital hypertrophy of retinal pigment epithelium. Next about Tercoat syndrome, there is medulloblastoma as well as glioblastoma multiforme. Next case is primary biliary cirrhosis. So, in primary biliary cirrhosis, there are inflammatory lesions like florid lesions around the ducts. X-ray is normal, MRCP is normal. The patient will be a young female patient mainly presenting with jaundice, pruritus, xanthelasmas as well as osteopenia. There is presence of anti-mitochondrial antibody. This is all about primary biliary cirrhosis. Next about primary sclerosing cholangitis. Patient will be an elderly male patient. There is associated inflammatory bowel disease in the form of ulcerative colitis or Crohn's disease presenting with jaundice, where there will be onion skin appearance around the bile duct. On MRCP, there will be multifocal strictures and dilatations which shows beaded appearance. This is about primary sclerosing cholangitis. Next is an alcoholic patient where there is cytokeratin 8 by 18 positivity or intermediate filament positivity. AST by ALT is more than 2. This is about alcoholic hepatitis. There is presence of Mallory-Denk bodies in alcoholic hepatitis. AST is higher in alcoholic hepatitis. AST, it is also known as SGOT. SGOT, AST. Cofactor is B6, that is the pyridoxine, which is transamin, and aspartate is converted to oxaloacetate. So transamin, which helps in the conversion of aspartate to oxaloacetate, which is a reversible reaction. So AST is higher in alcoholic hepatitis. ALT, it is higher in viral hepatitis. So AST or SGOT, the conversion, the mechanism happening there is cofactor B6 pyridoxine. Along with the help of that, transamin is helping in the conversion of aspartate to oxaloacetate, which is reversible condition. Next is in ALT or SGPT, alanine is converted to pyruvate, which is a transamination reaction. Here the cofactor is B6, that is pyridoxine. Next is Madris discriminant function. Madris discriminant function more than 32 is seen in alcoholic hepatitis, which is an indication of steroids. Hepatitis C infection. In hepatitis C infection, there is Councilman bodies or apoptotic bodies. Because of inflammation, there is portal tract expansion. Emperipolysis is eating of one cell by other, that is emperipolysis. Interface hepatitis is an autoimmune hepatitis. There is anti-smooth muscle antibodies as well as anti-LKM1 antibodies. Next, about complications of cirrhosis. Hepatic encephalopathy, it is a complication of cirrhosis. Earliest symptom for hepatic encephalopathy is altered sleep cycle. Specific sign is examiner when gives resistance to the wrist, it shows asterixis, that is the flapping tremor. Staging for hepatic encephalopathy, name is West Haven staging. When we do EEG finding, we see triphasic waveforms. End stage we see delta waves, which is the slow waves. Next is serum ascites albumin gradient. When it is more than 1.1, that is when the portal pressure is high. Along with it, when ascitic neutrophil is more than 250 per millimeter cube, it is spontaneous bacterial peritonitis, SBP. Drug of choice for SBP is cefotaxime. So, drug of choice for spontaneous bacterial peritonitis is cefotaxime. Next is a case where a patient having acute kidney injury. So, acute kidney injury in a patient with cirrhosis where FeNA is less than 1%. It is a pre-renal form of AKI. Most common is hypovolemia, which is ruled out. There is no sign of shock here. This is about hepatorenal syndrome, and treatment for hepatorenal syndrome is terlipressin as well as albumin. Next is a patient who is having platypnea as well as orthodeoxia. It is a position specific dyspnea. This is about hepatopulmonary syndrome. Next is liver diseases. The metabolic diseases associated with liver diseases. First one is KF rings. So, KF rings it is seen in Wilson's disease because of mutation in ATP7B chromosome 13. Here there is copper deposition in Descemet's membrane. So when we tell about KF ring, we should also remember one another thing, that is Fleischner ring. So Fleischner ring is seen in keratoconus. There is iron deposition in the epithelium. Just forget that it is now here we are only discussing about KF ring. So liver disease, the metabolic disease associated with liver disease, first thing about KF ring, which is about Wilson's disease, it is the copper deposition in Descemet's membrane. There is mutation in ATP7B chromosome 13. So now when I told about ATP7B chromosome 13 in Wilson's disease, we should also remember about ATP7A. What is ATP7A? Where is it seen? It is seen in Menkes kinky hair. Wilson's disease, there is decrease in ceruloplasmin, urine copper will be increased. Wilson's disease is associated with type 2 RTA. Prognostic index of Wilson's disease is Naser staging. Naser staging is bilirubin, AST as well as PT. So prognostic index of Wilson's, that is the Naser staging, Naser or Naser, NAZER, Naser staging index, it includes bilirubin, AST as well as PT. KF rings, 90% of the patients having KF rings, they will be neuro patients. 50% of the patients having KF ring will be hepatic patients. So they will be having hepatic disease. So treatment of choice is zinc, and if the patient is having this KF rings along with hepatic decompensation, add triandrene along with zinc. Next, about hemochromatosis. Prussian blue or pearl stain, it shows iron deposition in the liver. When we take MRI, we see black liver, that is because of iron deposition, and because of the susceptibility of iron, it shows black color in MRI. And this is everything about hemochromatosis. And the chromosome affected in hemochromatosis is HFE chromosome 6. It affects HLA. There is an issue with hepcidin here in hemochromatosis where iron absorption goes wrong, so there is increased liver deposition. So here in hemochromatosis, it can cause jaundice, diabetes mellitus, infertility, Brown's diabetes, restrictive cardiomyopathy, pseudo gout as well as hook-shaped metacarpals. Everything is associated with hemochromatosis. That means this hemochromatosis can affect liver by causing jaundice, it can affect pancreas by causing diabetes mellitus, it can affect pituitary by causing infertility, it can affect the skin by causing Brown's diabetes, it can affect heart by causing restrictive cardiomyopathy, it can affect skeleton by causing pseudo gout or the hook-shaped metacarpals. So everything is associated with hemochromatosis.